Most healthcare costs throughout America are on the rise, but there are some healthcare costs within Medicare that are actually drastically dropping and improving. So in this video, I'm going to show you which ones those are and why that's happening. Now, as our age increases, so does the risk of us having a chronic disease increase. And so I want to share with you, first of all, the leading drivers of healthcare costs. Number one, certainly is going to be cancer. Cancer costs Americans $200 billion a year for care. Heart disease, $110 billion a year. Arthritis, $160 billion. Look at this one, diabetes, $400 billion a year. That's actually spent on diabetes, healthcare expenses, dementia, $300 billion, and then stroke, $40 billion. And so I've done the math on this, and it's actually $1.2 trillion that is spent on these particular chronic diseases. Now I just want to share with you just a couple of very important stats that I found in my research. I think this is very, very shocking. That of the 65 plus population, 60% of all people die from either heart disease, cancer, or stroke. Okay. In fact, a very interesting stat is this. They say that in 47 of the 50 states, including D.C. as well, that heart disease is actually the top cause of death. 3 states, and it's actually cancer. Every 40 seconds in America, someone has a heart attack. Every 30 seconds, someone is actually dying from some type of a cardiovascular disease. Every 3 minutes, someone dies because of a stroke. And so the point is, the risk of us having these chronic diseases really grows with our age. And so let's talk about what is actually a chronic disease. This is my favorite definition. It's this. A chronic disease is a condition that lasts for 1 year or more. It requires ongoing medical attention, or it limits the activities of daily living, or both of those. Also, chronic conditions do not fix themselves and generally are never cured completely. And so the point is, as we talk about the expenses, we're really talking about the high likelihood of us being the senior population having some type of a chronic disease. And of course, with that chronic disease also comes a tremendous amount of expense. Listen to this, 40% of cancer patients will spend their entire life savings in the first 2 years of their treatment. 30% of all cancer patients will struggle paying their bills. They will have to borrow money to pay the bills, or they'll have to file bankruptcy because of this chronic condition. All right, so let's look at some additional information about this. So we've seen really the leading drivers, all these chronic conditions for this $1.2 trillion in healthcare costs. But I want to talk about why this happened. What are really the factors that contribute to this $1.2 trillion of expenses? So one of those drivers is actually simply going to be the providers. These are our primary care physicians. These are our specialists, outpatient type of providers that are treating people with these type of chronic diseases. Certainly these people are educated, highly educated, especially those that specialize in treating these different chronic diseases. They have a lot of education, probably a lot of educational debt, and so they really do demand high salaries because of that specialty training, as well as the educational debt that they carry. Number 2, it would be facilities. Now we're talking about hospitals, inpatient facilities, outpatient facilities, places where surgery is going to occur. A lot of technology in these places, which of course costs a tremendous amount of money to be able to not only diagnose but also treat people with chronic diseases. And then lastly, this would be drugs, medications. Sometimes these are meds administered into a hospital facility, outpatient clinics, could be chemotherapy. In fact, I think the average chemotherapy right now that would just last for 6 months, it ranges anywhere from $50,000 to $100,000 just for that 6-month round. So we're talking a lot of money. And then the self-administered medications as well. So these are the driving factors to this $1.2 trillion amount that Americans are spending every single year. Hey, if you found this video helpful and if you want to see more Medicare information just like it, then go below, right below the video, and you can give us the thumbs up as well as subscribe to our channel. And every time I put a new video, which is about 2 every week, you'll be notified of that video, and others just like you who need this vital information will get it it as well. All right, now we know this is a large bill, but is it primarily paid by the patients? No. It can be in some situations, but the majority of people are going to have some type of insurance. And with the insurance plans that are available today, fortunately, there is some type of a maximum out-of-pocket established by the insurance plan. So yes, $1.2 trillion is spent. Again, the majority of that's going to be insurance, but we still have out-of-pocket expenses. And of course, there are some limits. So we'll talk about those this year. Now, there are some people that are on what we call a marketplace plan. They're not an employer group plan. They went to the healthcare exchange to get that plan. And fortunately for those plans right now, that's the max anyone is going to spend if they're on a marketplace plan. The bill could be $100,000, it could be $500,000. Doesn't matter. If they're on the plan, they're going to be responsible for $9,450. Now, keep in mind, if there's a premium with that plan, and sometimes there is, depending upon the amount of subsidy a person's receiving through the marketplace, but sometimes it's zero premium, other times they have that. So it would be max out of pocket spent towards inpatient, outpatient care, medications as well, plus the premium. Now, if someone is actually in the Medicare system, one option that some people have opted for would be to be on an Advantage plan. We call these C plans or replacement plans. So this is someone that enrolls in Medicare A and B, but it's a private health insurance company that's replacing that for them. And again, they also are required to set maximums. And so this year, your Advantage plans max out of pocket, and this is going to be in some type of a plan that would be like an HMO plan, PPO plan. Now, in the HMO plans, you can't go out of the network. On a PPO, you can. But the maximum out of pocket, and again, this does not include prescriptions yet, but just for the inpatient and outpatient care, the max is $8,850 this year, 2024, and somewhere between $10,000 to $12,000 if you're on a PPO plan that allows you to go out of network. HMOs, you have to stay in network. PPO, you can go out. So what they do is they actually combine that in and out of network max out of pocket on the plan. And again, doesn't include medications yet, and so that's that option. Then another option people have is to do a supplemental plan. So this is somebody that's enrolled into Medicare A and B, and to get the financial gaps not covered by Medicare B, covered by insurance, they get a supplemental plan. These are also called Medigap policies. The two top plans right now are the Plan G. And so let me show you how I arrived at this $1,740. Now, keep this in mind. We're a nationwide broker, so I'm just giving you kind of an average price for somebody that's starting Medicare at 65. That G plan on average is about $125 a month, okay? And so when you put that number, $125 a month times 12, that gives us premiums of about $1,500 a month for that G plan. Now, there could be some states a little lower. There could some that's going to be higher. Okay, I'm just giving you that average. But when I say $1,740, I put that in there because that's $1,500 for premium, and that G plan covers all the gaps except the Medicare B deductible, which this year is $240. Okay, $240 for the whole year. And so that's where I came up with that $1,740. The second most popular plan today on the market for MedSup plans is called an in plan. Different letter, different type of coverage. And so what the in plan does, again, the premium is going to be lower. And on my average here, I'm just using about $100 a month. And there may be some places where it's $95 or $90, could be $110. It varies again, but let's just call it $100 because that's a good average. So now we have $1,200 in premium for the in plan. And then what the in plan does is we also have to pay that B deductible. So that is $240. So that's how I came up with that $1,440. But notice, I've got a couple pluses there because with the in plan, when someone sees a doctor, primary care, a specialist, or any kind of provider, they're subject to a $20 copay every visit. And then if they have to go to the emergency room for care, then they pay a $50 copay for that. So that's why I had to put those in. I don't know how many office visits someone's going to have, times visits to the ER. So again, that's going to be still to be seen. We don't know that. But the point is, when we talk about max out of pockets on the G and the in plan, we're paying our premium plus deductible, and of course the in plan a few more copays. All right. So my whole point in sharing this with you is all the plans are going to set some type of max out of pocket, and all these have to do with inpatient and outpatient. Especially when we talk about supplemental plans and drug plans, supplemental plans and Advantage plans, this is the most that we'll spend. But we haven't yet talked about medications, all right? So let me just show you this just real quickly. So what we're going to do, we're going to erase all this now that we see what we're spending on these plans, okay? And then here's what's going to happen. Watch this. We also have to pay beyond the inpatient, outpatient for what? we got to pay for prescription drugs. And so that's what I want to spend the rest of my video talking about here, is because in all these plans, if I have an Advantage plan, that was just for my inpatient, outpatient care. Now I'm responsible for medications. Same thing on a PPO versus HMO. And then when I get a supplemental plan, what happens? I also have to have a drug plan. We call those standalone drug plans. So again, this is all about Medicare today. And so when I decide how I'm going to get my inpatient, outpatient covered, then that also determines what my Part D plans or my drug plan options will be as well. Because what happens with the Advantage plans is they integrate them, they include those within the Advantage plan. If I have a supplemental plan, I get to pick the plan. There's usually 15 or 20, 25 drug plans in every zip code. So I pick the plan based upon the meds that I take and the pharmacy I want to go to. So up here, they pick the plan. In this system, I actually get to pick the plan myself. All right, so now let's look at the details of these prescription drug costs in addition to our other in- and outpatient expenses. Hey, Medicare can be very confusing. In fact, people make mistakes all the time because of how confusing it is. So what I've done is I've actually created a Medicare, notice this, Essentials Workshop, where you have the opportunity to really learn everything that you need to know about Medicare so that you can make Medicare decisions. There are thousands of people every month that watch this workshop, and we get lots of reviews saying that this is something that really was helpful to them. And so what you can do is down here below in the comments section, you'll see where it says pinned comment. At the very top of those pinned comments is a link. And you click on that link, what we're going to do is we're going to give you free access to this Medicare Essentials Workshop. And we want you to watch it because we don't want you to make any mistakes. All right, so this brings us to this particular chart. Probably one of the most confusing aspects of Medicare for years has been the way we pay for our prescriptions. In work plans and individual plans, pretty simple. You're on a medication. That medication is given a tiering number, maybe tier 1, 2, 3, 4, 5, but that tier number establishes our copay. And depending upon the tier, let's say a tier 1 may be a $5 copay, tier 2 may be $10, tier 3 may be $50, but whatever the copay is, on a group plan and a work plan, individual plans, that is a fixed copay throughout the year. Our copays don't change. But when it comes to Medicare, our copays can change and will change. And again, it's been very confusing to people. So I just want to clarify how this is working. So we're talking about, again, Part D plans. This is prescription drug plans. And these are for the medications that we self-administer. When I have an inpatient or outpatient situation, then again, in Medicare, they're going to be covered by my A and B, they're going to be covered by my supplemental plan, they're going to be covered by that Advantage plan. But the meds that I administer myself, this is when we're talking about Part D plans. Self-administered meds, cholesterol, high blood pressure, maybe insulin, if you're taking self-administered chemotherapy pills, all those things are covered by our Part D plans. And again, let me explain the system. Now I put 2023 in here. I'm shooting this video today. It's actually March 21st, 2024, but I'm putting 2023 so you can kind of see how this system within Medicare is now improving and actually drastically dropping. All right, so let's go back to it. So again, we're all talking about self-administered prescription drug medication. So in 2023, here's the way the system worked. The plans had a $505 deductible. Now, sometimes what that meant is that if the plan has a deductible, what happens is, now, well, look down here. You as the patient, you as the one who enrolled in the plan, you were 100% responsible for the deductible if the plan had a deductible. Sometimes they lower it, sometimes they eliminate it, but the majority of them do have a deductible. That maximum deductible is set by Medicare. And so if you're on a plan that has a deductible, you are paying 100% of the cost of your medications in this particular, what we call phase. These are 4 different phases. Remember what I said, the difference between Medicare plans and group plans, employer plans, individual plans. Those plans have 1 phase. Medicare has 4 phases in 2023 and 2024. And so what we have is phase 1 deductible. So if that medication retails for $10, you pay $10 and it applies to deductible. If it retails for $500, then you paid $500 and it was applied to deductible. The majority of people don't reach their deductible because they're on low-cost medications. But if I'm on medication that is above $505 on a retail basis, I had to pay that out of my pocket. And then once I've met that deductible, that then put me into stage 2. Stage 2, 2023 and 2024, what happens here is we pay no more than 25% of the cost of medication. Usually less, but no more than that. But what happens in this phase here, called initial coverage, is Medicare does something that's way different than anything you've ever seen, and that is they track the retail cost of the medication. They track it. And of course, it's tracked between the pharmacy, computer systems, and Medicare, but they're tracking retail. Now notice, you didn't pay retail unless you had to meet a deductible. You just paid 25% of that cost, but they track retail. And so they're taking what you're paying in copay and what the insurance plan is also covering. That's that total retail cost. And so if we ever reach that threshold, they call it, if we ever do, most people don't, they say about 9 out of 10 will never hit it. 1 out of 10 will. So if we hit the retail threshold because we're on a lot of meds or expensive meds, then we would be done in this phase and we would go then to what's called the coverage gap. Now, in layman's terms, this is a thing that we call the donut hole. Now, keep in mind, 1 out of 10 will reach that retail threshold and therefore go to the donut hole. Most people never will, but if they do, what happens here is, again, max out of pocket is a flat 25% coinsurance for whatever medication I'm on. So up here in this phase, normally people just pay a reasonable copay. Could be on a medication where I have a $45 copay, but let's say it retailed for $500. $500 retail, I pay a $45 copay, but if I go the donut hole now, I have to pay 25%. And that 25% of $500 would be what? A $125 copay. So that's why we say on Medicare plans, our copays can change depending upon the phase where we are. And so I pay this $125. Medicare now is tracking a different number. And last year, that number, I believe, was $7,400. It may have been $7,500 in 2023. But the point is, this was actually called TROOP, True Out-of-Pocket Cost. And so what that means is they're counting what you're paying out of your pocket plus the manufacturer in the donut hole. And notice this is where the manufacturer comes into play. They're one of the payers, and they have to manufacture. The manufacturer must discount that brand name medication 70%. So if I'm on a $500 medication, it had to be discounted by 70%, which is $350. But that $350 discount was applied to that number here. Which means what? The most I would have paid of that $7,400 was 25%. The rest of it was manufacturer discount, and also the Part D plan was responsible to pay 5% of that. Okay? So that's the way it works here. Now again, only 1 out of 100 people will ever hit that max number. But those who do will then go to catastrophic. And in 2023, the copay for catastrophic phase was 5%. So if you're on a medication that retails for $1,000, you would have had to pay $50 here. And the rest of that balance was actually picked up by Medicare. They're the ones responsible for that in 2023. So my whole point, all of this here really had no limit. Now, I may get through all these phases quickly if I'm on a real expensive medication, but the rest of the year, I still would have had to pay 5% out of my pocket. And I'm going to show you here in this example of a medication that retails for $13,500, and it's called Stelara. And so if someone was on Stelara, they would have gotten through all phases very, very quickly, but then they'd be here and they're paying 5% of the cost of that medication. Still a bargain, but it just kept going and going and going. All right, then what happened in 2024, because of the Inflation Reduction Act, they changed all that. So here's what's happening in 2024 this year. We do have a deductible still. It is $545. Again, your plan may waive that, they may reduce that, but it can never be above that. But if I'm in this phase 1 with a deductible, I am still responsible for 100% of the cost of my medications. And then once I reach the deductible, if I do, now I go to stage 2. And again, the most I'll ever pay is 25% copay. Most of them, again, are less than that. And now we have a different number. Medicare is tracking the retail cost of $5,030. But the same thing happens. Most people don't reach that. 1 out of 10 will. And once they reach that, whenever they do, whether that's in 2 months or 6 months or 9 months, once they reach that retail threshold, they still go to the donor hole. So yes, this year, we still have the donor hole. Again, max out of pocket is 25% coinsurance, and now the troop moved to $8,000. Okay, now watch this. Here's what changed. And this is why we're saying there are some medical costs within Medicare that are drastically improving. And this is where we see the change. Because now, if we ever hit the true out of pocket, and remember what that was, 25% of that was yours. That's the most. So the most you would have spent is $2,000. The manufacturer had to discount that 70%. And again, the plan picked up the other 5%. But here's what happened. Because of this Inflation Reduction Act, catastrophic now has moved to zero. So I no longer have this unlimited liability. Even though it was minimal at 5%, I still had to pay that. And on expensive medications, that was still an issue. But now, once I have hit that catastrophic stage, which out of my pocket, I would have spent $2,000 here, up here. At most, I would have spent here in the $5,030. I would have spent 25% maximum. Probably didn't spend that much, but I could have. So that would have been $1,200, and we'll just call it $60. It's about $1,257. So I got $1,260. And then if I had to meet my deductible there, so that would be $1,260 plus $545 plus the $2,000. Okay, that's going to put me about $3,800. That's the max I could have spent because now I'm here. And so the official number, what they're saying for this year, the max anyone would spend in 2024 would be anywhere from about $3,350 to about $3,800. So that's the max. Regardless of how expensive the medication can be. Again, Stelara right now, average person spends, its average cost of Stelara is $13,500 every single month. Had a guy the other day that was on a medication that cost $16,000 a month. Are they going to have to pay that? No. Why? Because now we have a cap for 2024. All right. And again, you can kind of see how they arrive at that cap. But that's the most anyone could spend out of their pocket because now catastrophic phase is zero. Now it's even going to get better in 2025. Here's what's going to happen. We still have a deductible. They actually lowered it for next year at $540. But here's the beauty. Number one, next year, the donor hole is gone. We have no donor hole. And so what happens is now we have a cap of $2,000 max out of pocket on medications, $2,000. Okay, here we had no max. Why? Because we still had 5% coinsurance. Here, because we still have the donor hole this year in 2024, we still had liability. Again, it's limited at least, which is better. But even next year and beyond after that, that $2,000 is the most anyone will spend out of pocket. And so if they're on a medication like Stelara, it's $13,500 a month. And so you're talking a medication that is, $150,000 for the whole year for that medication. And it's what people need for Crohn's disease, psoriatic arthritis, those types of things that, again, are chronic. And so that's what we're saying. When it comes to chronic conditions, medications are certainly going to be needed to treat those conditions. But now, because of some of the Medicare changes, we're seeing that drastically reduce. Yes, people still have their max out of pockets on their supplemental plans, on their Medicare Advantage plans, but when it comes to prescription drug plans, we're seeing those drop wonderfully.